Well, we're going to get cracking here. It's a real pleasure to have Marc Cherniwchan with us, who's going to talk to us on our staff wellbeing rounds. And the title is Technological Tribe Survival in the New Millennial Jungle. I've had a very pleasant chat with Marc this morning, and he is a career emergency physician who's developed a huge passion for his current interests, which is with the Physician and Family Support Program with the AMA.
Victor may not be able to hear you.
Is that,
Okay. That doesn't really move very far.
I read with interest, Marc, some of your titles from your previous presentations, including The Medical Tower of Babel, Weathering the Perfect Storm, Swimming with the Sharks, and The Technological Tribe. So I'm sure today's chat's going to be very, very interesting. So you're very welcome, and thanks for coming.
Well, thank you for having me. Victor, can you hear me over there? And can you all, the rest of you, hear me and see me? Maybe just wave from the other side. Okay, thank you. So let me know if there's any problems. And also, we would ask that you keep your speakers on mute over there unless you have a question. This is an open rounds at any time if there's questions. Then just press the button and I'll answer them as we go along. But when you're done the question, if you're able to just push the button again so it mutes, it stops the feedback and everything else. All righty. So let's start. This talk is called The Technological Tribe, Surviving in the New Millennium. Now, before we kind of jump in and talk about that stuff, I'd just like to do a bit of housekeeping. And the first thing is we're going to spend the first bit of our time talking about the actual Physician Family Support Program, because we're finding that in the 12,000 plus doctors, residents, and learners in the province, a huge number really don't have any idea of what we do, or they have a very kind of skewed idea of what we do. So we'll spend a bit of time on that so you walk away really understanding what the organization is and what it can do for you, since you're paying for it largely. And then I'm going to hand out some evaluations at the end to the people here. And for those of you who aren't here, if you simply email Teresa Lizen with any thoughts you have on this, we read every one of these. And this is a living kind of presentation that we do. They're changed instantly, very quickly after evaluations by you folks. So we pay a lot of attention to those. All right, let's start. What's this?
Thumb screw.
Thumb screw. I hear thumb screw. Do I hear anything else?
Ancient lock.
Ancient lock. Well, maybe this will help you. Okay, what about this?
Oh, glasses?
Close. This, in fact, is the first microscope. And this is what you saw through it. And this occurred in 1676, Anton van Leeuwenhoek. And it allowed us to move from a theory of vapors in medicine to a theory of germ disease and underlie the basis of public health. So what we're going to do today, in fact, is take the microscope and turn it on ourselves, which is an entirely new hidden world to most physicians. And we're going to look at examining ourselves for the next half hour or so. Now, here's a startling statistic. 1/3 of MDs will experience a condition that will impair their ability to practice medicine safely. And most people, when I watch the audiences, when I give this talk, start to think back in their past, and then they'll think, oh yeah, when I had a heart attack, I was out for a month. Oh yeah, when I was in that accident. Oh yeah, when I had depression. And in fact, 1/10 of the audiences that we have that are medical will have some type of substance abuse problem during their career. Really staggering numbers when you think about it. So in a room of 100 medical students, 10 of them will suffer from that condition alone in their career. So it's a big issue, actually, for us, given, again, the numbers I said of having over 12,000 people in the province. And up till now, largely it's been handled behind closed doors. So most of what goes on is invisible to the general medical population of practitioners. There's a feeling that there's kind of an old boys club hiding behind the doors that makes the decisions for dealing with issues like this. But what I'm going to do is open those doors today, and I'm going to take you behind them, and I'm going to show you how it actually works. So a lot of the mystique, a lot of the fear, a lot of the wonder about that will vanish and be replaced by fact. So now it's quite different. We have a physician family support program in Alberta that's really been running since 1998 and has its origins all the way back to 1982. And it's actually part of a huge organization around the world. So the Canadian Physician Health Institute, run by the Canadian Medical Association Foundation, is a huge body that collects money to help physicians in need. There's a forum of physician health programs, because there's one in each province, that we all meet and discuss how we deal with things. And then there's a federation of state programs all across the United States we meet with as well. So we're part of actually a vast organization of organizations helping doctors. And we have conferences just like everybody else. This is one that runs in each province every year, and then there's one that runs in conjunction with the British Medical Association and the Alberta Medical American Medical Association on their joint soils each year as well. So really a wide exchange of ideas looking at how to deal with doctors who are struggling. The shared goals of all of these physician health programs are important. We encourage physicians to seek and receive assistance for health issues. We're accountable to the profession, and our job interacts with that of the regulator. And I'm going to spend a bit of time talking about that because there's a tremendous fear among physicians, particularly since the new guidelines from the college have come out about having to report on colleagues that you think are having trouble, things that will impair their practice in any way, or for yourself. There's tremendous kind of worry about whether stuff that we do with doctors who are in trouble will actually get back to the college. And I'm going to talk about how that works in a minute. We're largely about preserving the career life of a physician and the integrity of their personal life as well as their professional life, and we're advocates for them along all stages of that. There's been a kind of a growth in the scope of how physician health programs work. Began in the 60s when really the only thing that was on the radar was some type of substance abuse. And that began to be looked at by the professional medical associations across North America and in Britain and elsewhere. In the 1970s, it moved into depression and other issues that were complicating practice for physicians. By the 80s, we looked into other impairing conditions, some of them cognitive. People were growing older. People were suffering from early dementias and still in practice. In the 1990s, at the time of great social change in Alberta, those of you who are my ilk will remember, was the year of the disruptive physician, the decade of the disruptive physician. And a whole amount of energy was spent on dealing with behavioral stress and issues. And now, in the new millennium, it's a cornucopia, okay, a growth industry of problems as society becomes more and more complex and the issues facing health become more and more complex. To get back to the point I was making earlier, we interact with the College of Physicians and Surgeons. So, and I'll show you the statistics in a minute, physicians can either come to us directly and talk to us and say, I need some help with some issue, or the college may direct them to us because they've been brought to the attention of the college for some problem, or they themselves have approached the college not sure what to do. So we have a liaison with the college. The college will often ask us to be involved in looking after or coordinating a physician's care while they're sorting out stuff with them. But it's a very, very unique relationship where both sides have information they keep confidential. So even though I'm going to open the doors today and show you largely how we work and what we do, the individual cases that we have are extraordinarily highly confidential. So when I take a call, say, from a physician who's in trouble for some reason, and I find out a whole bunch of things, that file on that physician is kept as a Swiss, almost like a Swiss bank account. It's a numbered account in a locked vault that nobody has access to, not even members of our own organization. Anytime we discuss that case, it's non-nominally. Other than a small group of us that have to coordinate the care for a particular physician, no one else knows about that. College doesn't, the hospital doesn't, Alberta Health Systems, the university, nobody. Not even the rest of the medical association. And it remains like that. All written documents other than that are shredded after conversations. As soon as the case is closed, all the documents are filed in a summary and on a numbered basis and everything destroyed. So it's highly confidential service. And I think it's important that every physician who in Alberta understand that when they call us, they can tell us stuff and it remains that way. The only times that we have to divulge information to the college is when we uncover, in fact, a boundary issue or an immediate risk to the public. But there have been many, many times where physicians have come to us and we have said, you know what, you really shouldn't be in practice at this point till we get this sorted out, where we have helped them go off practice, arranged care for them, arranged assessment for them, and later, at the conclusion of all that, we've gone to the college with them and said, we now have something we need to report to you. So as long as there's not an immediate risk to the public or to a patient or an ongoing issue of concern like a boundary issue, we often handle things quietly on our own with the doctor and then go to the college with them afterwards and make sure that the mandates of the college are met with them. And that's been a very successful strategy for a long time, well received by the college. So we actually have quite a good relationship with the college, and I have to say that after doing this for 5 years now, I'm very impressed with how supportive the college is of that. If a physician is in trouble for any reason, including substance abuse or alcohol addiction or cognitive disorder or anything, they are immensely supportive in trying to maintain their practice or find them a practice that will work. It's only in the case where a physician is actively malfeasant that the college is very draconian in terms of coming down and making sure that the public is safe. And in 5 years of dealing with many, many cases, we get roughly 1,000 calls a year. I've only seen one case of that where I thought the college was acting very appropriately. So what do we actually do? Well, a huge part of this work is what I'm doing today. So over the past 5 years, I've over 50 times I've been out in the province talking to doctors about health and issues like that and how they can access us and what services we can provide. We have a 24-hour call line, and I'll give you the number right at the end of this talk, that anybody can call us at any time. There's always one of us available to talk on the phone for any issue, from I need a family physician who speaks Urdu to this doctor in my operating room is high on cocaine ripping apart the operating room, what do I do? You name it, we probably have seen it. And in fact, we're a good source for all of those things. The top of the pyramid, which is a smaller number of things, is where people have complex problems, complicated enough that we actually have to enter them into a program and walk with them down a path for maybe 5 years to get everything unraveled. And that's what we call case coordination, and I'll talk about that in a minute. And that's the pyramid of the work that we do. Here's who we are. As of 2014, we have a program director who's a physician down in Calgary. There's 11 of us who are trained and mentored in the program by other people. Most are invited or interviewed if they apply, and all have either experience or tremendous interest in mental health issues. And they come from a wide variety of backgrounds: family medicine, emergency medicine, pediatrics, psychiatry, you name it. We have somebody devoted to education across the province. And then for the apex of the pyramid, where we're looking at people who need a lot of help, we have 4 of us across the province who do that work. And we have administrative staff, and we have some coordinators, and we have access to about 400 counselors across the province who are highly specialized in nuance for boundaries, confidentiality, issues from everything from dealing with ADH children in a medical family to cognitive decline and career transition in a seasoned practitioner to issues of infidelity within families, you name it. All of those issues we have people that are specialized for, and all are vetted by the organization before they join us. Well, who do we see? Well, there's about 10,130 doctors in the province, another 2,000 residents, and about 300 students. And of the problems we get about 700 to 1,000 or 1,100 calls a year. That represents maybe about 6 to 7% of the population that's in practice or in learning at any one time. That's big, actually. Most physician health programs only get 3 to 4%, and it speaks to the fact that we have a very aggressive marketing campaign with the medical schools and the universities to say, we're out here, call us if you need help. And we have a lot of experience here. So we're trusted by the population of doctors. Many of them call us for problems and 2 or 3 years later call us for other problems again. Of those calls that we get, many people think we're an addiction service. But if you look at the tiny blue line at the back, only 3% of our calls are related to primary addictions of some form or other. 66% of our problems are related to family issues or stress or burnout. 2/3 of what we're dealing with are doctors who are struggling just with what they do. Many of them will, along the way, self-medicate, but it's not an issue for them. The issue is the work environment itself. Now, the purple line there, which says about 9% and says occupational issues, is an interesting one, because what we're finding is that's increasing every year. So it's up to about 13 to 14% where people are having problems in the workplace. It used to be called the disruptive physician. We're now calling it the toxic workplace, because we're finding, as I'll show you in slides later on, it's quite complex what happens in those environments, but it's becoming a bigger issue every year. So here's your typical roadside in Italy, and not particularly helpful. And the reason I put it up is because evidence-based medicine, and now the new kid on the block, metacognition, which are the darlings of science in medicine, basically were not going to help us that much here. I'm going to be presenting you data from time to time, and I'm going to present you slides, but think of it as comfort food, something you can anchor yourself on, because doctors have much more difficulty with what really is helpful in this field, which is ethnology. Ethnology is a branch of sociology that studies exotic environments, and it uses structured interview techniques to try and get a rich narrative of what's going on. The closest analogy for that in anesthesia would be in the quality improvement field, when people are looking at things going wrong, and they create an environment where they look at root cause analysis. So this is an epidemiologist who wrote a beautiful line which really describes it. Large databases rarely contain the critical material needed for understanding. Major advances come from voluntary debriefing. So when we go to these international conferences, we have plenary sessions and we have science topics on how many doctors are depressed in this thing and what intervention program worked to help them. But what is extraordinarily helpful are the sessions where there are open mic sessions, where we might be talking about fatigue and stress, and individual doctors come up to the microphones and describe the experiences they've had or they've had with dealing with their colleagues. That rich narrative provides the really useful information, and it's what I'm going to be addressing most today. So we're going to talk about lessons learned from the last 5 years in the PSFP program. Lesson 1, never underestimate the power of shame. Shame is different than guilt. So guilt rules families, shame rules the medical profession. Guilt is where you feel badly about something you've done. Shame is where you translocate that to feeling badly about yourself after a certain point. And we are really experts at it, because right from the get-go, if you look at the psychology of who gets into medicine and who survives in medicine, it begins long before they enter medical school, where they're encouraged in a conditional way to strive, and their value is based on striving and being successful and being in the top % of their class and being in the top half of the medical school and getting into the right residency. They have a self-oriented perfectionism. They expect themselves to be perfect. They think other people around them expect them to be perfect, and they feel that they have to be perfect because they're a doctor. It's okay to screw up if you're a lawyer. It's okay to screw up if you're a car salesman, but I better not screw up if I'm an anesthetist and the airway depends on me. That's a huge burden to place on someone daily for 35 years. It's promulgated and continued in medical school, and here's your typical residency, okay, where all along the way, okay, your learning is shame-based. I'm thinking right now, I don't have time in this thing, but if you think about the times that you have been made belittled during the times that you've been in training, everybody has an extensive collection of stories as part of the process. So, and it's not because the people that are doing the belittling are bad people, it's that they're so damaged by their own careers and their own training that that's how they know to react, as a defensive attack posture when they themselves feel threatened about things. So it's a very difficult culture to avoid or change, but it's a very real, potent effect that has an effect on practice all the time. The harshest court in the land is the court of your own conscience. So if there's a mistake in the operating room, it will be internalized, and it will begin to affect your work. It'll begin to affect the work around you of your colleagues, your interactions with your colleagues. You'll become irritable. Shame ruled. It is very difficult to underestimate the power of shame. A couple of other things about shame. The denominator is very important. So in my first year of practice, I was sued for $750,000 for a difficult head injury case, for what was really a good practice. And CMPA demanded we fight it and successfully dealt with it because they said it was well documented and they did not want a precedent set on this case. But it was devastating for me because I had a good head injury practice and had to fight to avoid admitting and CAT scanning every head injury I saw for 3 years after that because of the trauma of that event. I got a package and I thought it was a Christmas package from home, and it was a $750,000 lawsuit. So if I had been in practice like I am now, 33 years later, and 100,000 patients under my belt, it would not anywhere have been that traumatic. Vicarious shame. There's a trickle-down effect of shame. So if somebody does something bad, an adverse event happens in the OR, somebody beaks off at someone, people around them feel that shame and they distance themselves from that person. And it makes them feel uncomfortable. It makes them remember shames they've had themselves. And there's a pall that falls through the community and stays there. It lingers like a bad smell for a long time afterwards. And that's a huge factor in the practice of medicine. And the most important point, I think, in the university setting is the last one. There's data coming out now showing that not only neuropsychologically, but neurophysiologically, shame inhibits learning. So if a mentor shames a resident or a student, it's probably the stupidest thing they could do because it inhibits their ability to learn from the experience. They're just going to repeat it. Their brain is shut down. It cannot lay down the memory needed to, in the correct way, to learn from the experience. The end result is a culture of silence where people clam up and don't communicate. And it just stays there as a bad experience, a shamed experience, and one to be avoided next time. And this is true at all levels of the socioeconomic strata, if you like, of medicine. One of the biggest issues that we see in surgery and anesthesia suites is reactions to error and shame. And the typical reactions to an error that's occurred, I mixed up the drugs, I gave them adrenaline instead of phentolamine, whatever, and we've seen that kind of stuff, or I gave them the wrong dose of heparin and they died because I used the wrong heparin vial, is the ones you see there. A litany of bad emotions and powerful feelings that really inhibit the ability to move forward. There's now research on the Eastern Seaboard looking at taking the principles of mindfulness medicine and applying it to error. So let me give you an example. I had a patient who came in with a dissecting thoracic aneurysm that I could not pick up. It was a Marfan's, 30 plus years old. Sent him home. He presented the next day dead, ruptured all the way down his root. So I came to work today completely didn't know about this, and found out that his family was there wanting to speak to me. He died, and that he died. I found this all out in an instant. Mother was a retired nurse. He was engaged. His fiance was there. They'd spent the day looking up Marfan's on the internet. Wanted to ask me why I hadn't picked up this Marfan syndrome. So I spent actually a year with that family. I stopped my practice, instantly went down, sat with them. I did not call CMP. I did not tell them. I went, sat and talked to the family for half an hour. Yes, I thought of it. I didn't think he had it. And on and on and on. Explained everything to them. I opened myself up to their feelings, and then I spent a year with them trying to discover if other members of the family had Marfan's. It was a closed adoption. We had to try and get geneticists to take locks of hair and find records of his family, and eventually presented his case at rounds, and then years later met the family again when the wife's husband presented as a dissecting aneurysm, and I looked after her. And the whole experience was a very uplifting experience for me as a physician to walk through that process with them, because of those principles there. My colleagues, I opened myself up to my colleagues and their opinions, and them all saying we would have done the same thing, Mark. I was open to looking at my own compassion for myself and others, and I walked away from it a better physician. Whereas if I hadn't done any of those things and clammed up, none of that would have happened. So the take-home point from this first point is, because of a culture of shame, and because shame is so prevalent in medicine, if there is a call for help from a physician, it will not come as a call for help. It will come very obliquely. Hey, you know what? Mike, I haven't seen you for a while. We should go for coffee. We should go for coffee. How you doing? How are you doing? You doing okay? And really what the person is asking is, would you take me for coffee? I'm not doing so okay. That's how it will appear. The tentative little tentacle thrown out there to see if there's an environment where maybe I can talk about what's going on with me. So the take-home point is have your radar up, because the call when it comes will not be a yell, it will be a whisper. Point number 2 from 5 years. Nothing is lonelier or more overwhelming than the practice of medicine. So we did a wonderful experiment a little while ago where we presented data showing the modern miracles of medicine. So this is a glomerulus, only it's been retrieved from artificial zero, about 3 degrees above artificial zero, with the glomerulus intact. A remarkable feat technologically, and kind of lays the groundwork for the holy grail of transplant medicine, banked human organs. So we present this, and when we show that, you say to the audience, whether it be medical students or seasoned professionals, well, okay, all these miracles and you're involved in it. Wow, what could be better? Tell you what, let's give you some money. We'll pay you what you would make as a salaried physician. We'll give you benefits. We'll give you retirement. Just walk away. Put your stethoscope up and walk away. Now, medical students are quite fun when you do this. Virtually everybody puts up their hand. Okay. Doctors in practice, no, they don't want it. They're thinking about it. So we say, okay, let's make it a little bit more sweet for you. We'll give you $1 million straight up. We'll give you 10 million straight up. We'll give you 100 million. Just walk away. Never pick up the stethoscope again. And the interesting thing is virtually everybody has their price. Virtually everybody. And then you say to them, well, what would you do? I'd go to Africa. I'd help them there. What would make medicine so bad here that you would give it up for cold, hard cash? Okay, not because you saw God or because you suddenly discovered you wanted to teach European history. No, just for cash. That you would give it up, and then you go to the most destitute place in the world to help. Well, it's interesting. It has to do with things that aren't medical. It has to do with what we call the perfect storm. All the things that you're faced with that you never ever get trained for in medicine, which really make up your working day, and that you have to kind of learn on the fly and in an environment that's a pretty tough environment, largely shame-based, largely belittling. The end result for that is that doctors often reach the panic button, and there isn't one, because no one's taught them how to deal with it. They feel swallowed up, okay? And they become lonely. I remember I've had my series of lawsuits over the years and my series of complaints to the college and the hospital. And I remember the first time I got a complaint to the college, I was devastated. And once again, I thought I'd done a great job, and of course some adverse event had happened I couldn't have predicted, and I was just devastated. And I'm walking around, trudging down the hall, and a surgeon comes down from upstairs. This was at the university here, excuse me, and says, come here, I want to see you in my office. And we go into the soil utility room, and he shuts the door. And says, hands me an envelope, and I open up, it's my case. He said, the college asked me to review this. He said, I just want to let you know I did. I couldn't find anything wrong with what you did. And the reason I'm telling you this is I'm not supposed to, but nobody told me when I had my complaint, and it was the loneliest experience of my life. Thank you. So that was the voice of experience decades before we ever have a talk, recognizing how important that was and what a huge difference that made to my practice that day, that week, that year. Here's an interesting study looking at residents. If you look at DHM criteria for clinical depression, not you're sad, no, actually you're biologically, endogenally depressed, 20% of them meet the criteria, okay, in this study. 15% of them working over 80 hours a week. 20% of them have needle stick incidences occurring, okay? And 10% are in a motor vehicle accident within a year. Like, this is pretty hard data that, like, it's affecting them physically. It's not just, I'm sad and I'm working hard, I'll get over it. Like, you can die doing it. So the take-home point from the fact that it's a lonely experience in medicine is like that surgeon did for me, let them know you've been there. Let them know they're not alone. Whatever somebody comes to you with a problem or you hear of a problem, make a point of going over and let them know that you've been there. This is the door to the exercise yard in Alcatraz. So the third lesson I'd like to talk about from the 5 years of work in this field is a transformed physician can transform medicine. So what do I mean by that? And here, what I'm talking about is physicians who are struggling with addiction. Again, primary addiction, a small percentage of what I see, but a very important percentage. It is amazing. If I was going to start medicine again, I would go into addiction medicine almost certainly, because it is a profound thing to see someone who is struggling with these issues on their back and it's ravaging their life on all planes. They go away for treatment, they come back, and you sit down with them, and they're intimate, they're engaged, they're real, okay? They're focused, they're clear. It's like Leonard Cohen said, going clear. And the rest of your day looks like such bullshit compared to that. It is so phenomenal a transformation. And these people, when they come back, many of the avenues for their practice, they can't go back to. And what they do is they rise like phoenix birds and create new avenues of medicine. They find a role for themselves. They're highly motivated. And they look and they discover something that hasn't been done and they pioneer it. And there are beautiful examples that I've seen over the last 5 years of people reinventing themselves and reinventing and filling niches that never even needed to be filled, and creating new parts of medicine that were all because of what happened during that addictive process. The take-home point from this is they have to be trusted by someone to be given a second chance. And trust is what happens after an event has occurred, not before. Say, well, we all trust each other. Well, actually, you haven't had a chance to really trust anyone yet. We just assume everything's going to be okay because of our training. What matters is if someone falls down, do you trust them to get back up again? Do you trust that the treatment has worked, and are you willing to give them a chance? Many doctors aren't. All it takes is one that is, and the phoenix can rise. Addiction is a chronic disease, and yes, there's recidivism, and yes, we have all sorts of things in place to prevent that, and it's minimal, actually. But the stigma associated with it is massive. And the loss of that physician in the mix and what they can offer, being clear and being focused and being real, is profound. Work is the last place to go. So here's my climbing sweater from my burnout phase. Here's the license plate from one of my colleagues. Okay. When you study physicians, at least half don't want their children to go into medical school, and we lose the equivalent of 3 to 4 classes of physicians to suicide every year across North America. Our data and the data across the state suggests that from the time a physician starts getting into trouble till the time they've come to us, they've lost between 5 and 8 years of their life. And by the time they come to us, and it's showing up in the work environment, that's usually the reason, the rest of their life is devastated. It's a viper's pit of problems we have to sort out financially, maritally, parenting, socially. And that's why we often enter for 5 years with them to begin that process and walk through with them that process. So the take-home point here is if a colleague asks for help, they probably have needed it for a long, long time. And yes, there is a time window here. The sooner you can get them to us, the sooner that we can meet with them, the sooner we can get things going, the better. Next point. The disruptive physician is a distressed physician. So here's a beautiful description of the surgical swimming pool written by a surgeon. Okay? Any unidentified colleague is a shark till proven otherwise. Don't bleed, it attracts other sharks. Get out of the water if anyone's bleeding. Counter aggression with more aggression. And it's not just the surgical environment that thinks like this. There's a kind of a new postmodern medicine and mentality that we're seeing. So on the wards, you hear comments like this. when you're talking to someone on the phone. As everybody, overstressed and overwhelmed, hunkers down, puts up the silos and tries to protect themselves and anything they can to minimize the worsening of the stress-ridden day, and becomes more and more an isolated environment, which is a setup for a toxic environment. So what takes a doctor and moves him from here to here is not very much. We're seeing a rise in disruptive behavior every year, about a 3 to 5% rise. In this 1 year alone in this hospital in the middle of the States, 300% increase. The interesting thing was when you studied these people, all of them were highly stressed. More of them than half were filled with anxiety. Half were burnt out. But none of them had any substance abuse problems. None of them were sociopaths. And only 14% of them had any access to stuff on the DSM scale indicating, maybe we should sit down and show you how to talk to a nurse before you throw a scalpel at her. In other words, these are people who are normal people who are put in toxic environments. Now, here's an interesting study done by the province when we looked at stuff in 2010. And you found that only about 26% of the province's physicians felt engaged in their work environments at all. Now, a similar study was done in Covenant Health, which showed about 36%, but when you parsed out trust, it was fascinating. If you were in the first 3 years of your practice, where you didn't know anything, you were scared of everybody, and you wanted to consult widely, you trusted people. If you're in your last 3 years, and you had a beak on and a lip on, and you didn't care what you said to anybody, you were going to say what you wanted to say before you left, you kind of trusted people because you didn't care. But if you were in the middle, where you had some experience, and you knew that you could make a difference and stuff, trust was recorded at 9%. 1 in 10 people trust the people they work with in the hospital system. The approach to a disruptive physician in the past has been punitive. They're viewed as the sharp end of the stick. They're viewed as disruptive, and that things have to be punitive or remedial to deal with them. And whole systems have been put in place for this over the last number of decades. Nowadays, we look at them as the canary in the mine shaft. They're simply the one who was in the position of the highest stress, who was the first to die of the toxic fumes. And now we look at the entire environment when we look at these things, and how important it is that the whole system be examined, how important mentoring is, how important all the parties are in making a difference. This is a busy slide, and we don't have a lot of time, so I'm just going to gloss over it by saying that, once again, a huge percentage of the work I do in case coordination with the most difficult cases are related to disruptive toxic environments. Now, this is an interesting study that shows you how complex this is. So this was a study where we went in to a surgical environment in Edmonton here that opened their doors to us so we could look at things over about a year plus. And you can show that in that environment, even though people feel very engaged and feel and they still love coming to work, very few of them felt they had any voice in making a difference. Less than half felt valued at all. So it's quite complex looking at people's emotions in these environments where things are struggling. When we looked at trying to make sense out of that, it was interesting that 36%, about a third of the people that we looked at, looked for somebody to provide them with a solution. We realize we're having trouble. We realize that there are disruptive elements in our environment. We realize that we're angry and we're not getting on well together. Fix it. That's what you're here for. Just tell us how to fix it. The other interesting thing about it is that 13% feel it's all outside of us. It's too big for us. Alberta Health Services doesn't give us money. We don't have what we need. We can't do what we want. It's hopeless. But 15% viewed themselves as agents of change. And this is not related to physicians. This is across the board. So when you bring everybody in a work environment together, nurses, porters, orderlies, anesthetists, surgeons, everybody, buried in that group at all levels are people who are self-motivated initiators of change, latent solvers just sitting there waiting for the right thing to light them. One of the most beautiful comments that came out of the rich narrative that we looked at when we talked to people and asked them to write about this was this wonderful statement from the junior person, I have very little clinical knowledge, but I do have ideas. And it was the saddest comment on the thing, because right underneath it was a second comment, which was, but I'm frightened to say them because I feel people will put me down. Never underestimate the power of shame to prevent innovation. Take home point, everybody must have a voice and be recognized as having something to say. Everything will flow from that. There has to be an environment where the porter can say something and let him, because they often help me in cardiac arrests. I say, does anybody have any ideas? And the porter say, well, I don't know much about medicine, but it seems to me this electrical lead has fallen off. Yes, yes, it has. Thank you. They do have a rhythm after all. Last teaching point. Real change takes time. Leaders tend to feel that it's up to them to affect change, rather than having an environment where everyone can be a leader and affect change. A classic example is, I'm a good leader, I'm onto this physician health stuff, so I'm going to go to the Christmas party and be part of the Christmas party and show up for the troops. And I'm going to put a Santa Claus outfit on, I'm going to look goofy, and they'll love me, and I'll be a good leader. Okay? So there's a built-in parochialism to that. There's a built-in kind of patronage to that does not go unescaped. In fact, if you look at systemically trying to change things, even that's fraught with problems. So in the accredited colleges for graduate medical education, when they looked at limiting work hours for residents and mandating that, colleges said, absolutely, we'll do that. In fact, what everybody did was then cram 80 hours of work into 40 hours when they actually studied it, making it even more difficult for people to maintain their sanity. When they've looked at brief interventions, let's have 3 sessions, let's have 2 sessions, and let's just have physician health session, and then it'll be good if we pay attention to that. Those have been proven to be ineffective. So it's actually highly nuanced to affect real change in a work environment that involves multiple individuals, and it requires commitment from the entire organization at all levels over time. Can it work? Yes, it can. Here's a beautiful example. This is the deanery in London. It's run by this wonderful little rheumatologist. She's a 5'0". She weighs maybe 100 pounds, and she's extraordinarily bright. She has a budget of 400 million pounds, and she looks over 10,000 learners. And she luckily holds the purse strings for it, so she can say, if you don't do it, I'm going to do no money. So she went to the hospitals, and she came into power at a time when labor law in the European Union said people can only work 45 hours a week, and all the residents were working 80 hours a week, the way I showed you. So she went to the hospital and said, you can't do that, and the residents aren't going to fix that. That's not fair. You as a hospital are going to fix that. And then she was bright enough to leave them alone. And they did all kinds of innovative things to get the money that they needed. They put in teams to go around in the hospital and deal with crises at night. They eliminated redundant and wasted lab tests and ECGs being done at 6 in the morning. They found all kinds of ways that they hadn't looked at of thinking outside the box. And then she said, you know what, maybe I better check and make sure we're not killing people because they're only working half as hard. And she studied what happened to patient outcomes. And patients survived. Patient mortality went down. ICU transfers went down. Deaths in the first 24 hours went down. On a variety of indicators, patients did better if you treated doctors better, and saved millions of pounds in 2 institutions alone when that was studied. So real institutional change can occur if it's thought out well and it involves all the players. Now, I realize that you guys have to go to the operating room in a very few minutes, so I'm going to finish with one point. And I'm going to give you an example of how hard cultural change is. So in the surgical environment, we said to them, who were struggling and worked with for a year, we said to them, we'd like you to do a very simple thing. We'd like you to go away as individuals, because really the only thing you can change is yourself, and just make this one change. When you go home today, spend 5 or 10 minutes and ask yourself 3 questions. What inspired me today? What surprised me today? What touched my heart? Just ask yourself those questions. You will find this a very difficult thing to do because it takes 5 to 10 minutes. That's a huge amount of time when you're texting, a huge amount of time when you're looking at stuff on Google. You can lose a lot of internet time. But it will make a big difference because the trickle-down effect...
There are 10 minutes remaining in this video conference session.
Thank you. So if the trickle-down effect is if you think about something that inspired you and then the next day you go back and say, hey, listen, before we start, you know that case where the guy became unstable halfway through and you did this thing? Like that rocked. Like that really rocked. And you did nothing else but did that. The environment has changed. Then that person will do that to someone else. And all of a sudden, there will be change. Now, the reason I bring up this slide, this is by Rachel Remen, who's a really profound leader in terms of integrative medicine in the States, and her principles are now integrated in more than 50% of the medical curriculums across the United States, is that we asked the surgical group to do that, and then we came back a number of months later and said, how many of you have done that? More than every night? Nobody. How many every once a week? Nobody. How many did it once? One hand went up. Okay, now that's an important point. And what it shows you is that you have to, as if you're a leader or you're involved in this work, recognize that typical institutional change takes 7 years. It's a long process, but the effect will be profound for the next generation if it's put in place. So I hope with these few teaching points that we've discovered over the last 5 years working in this work, and with a brief overview of the program that I've given you here, you'll feel comfortable about calling us as a leader, as an administrator, as the head of a department, as a working doctor, as someone concerned about a colleague, as somebody having problems on your own, and any of those levels at any time, and have a confidential conversation with us. We have extraordinary resources to help you, not just in terms of counseling, but in terms of things to help you with assessment, things for career transitions, financial assistance we have to help doctors if they're in trouble. We are an extraordinarily rich province, and that is reflected in this program. We have a huge war chest to help doctors, and we use it, and we have done that, and we will continue to do that. And I hope that also from this talk, what I've been able to do is take what was a closed door and show you that it's really a series of doors that open, and each time you open one, you discover a deeper level of interest and complexity. And at the end of it all, the journey's been a wonderful journey. And for those of you who are interested in getting involved in this, I hope you'll phone me about that too. And I'd like to conclude by just giving you the number that you can call us anytime you want to look under the microscope, and it's right there. And now I'd just like to open the floor to any questions anyone might have, and to thank you all at all the sites for coming in early and participating. Any questions or comments?
Marc, on behalf of us all, I'd like to thank you for your very deeply challenging teaching. And thank you for your work with the Physician and Family Support Program. I think the passion for what you do is very evident. It shows, and it's very touching. I would like to invite people to ask questions if they do have any. I have one myself, but maybe folks would like to sort of ask their questions first.
I have one, Mark, if I could ask it. You mentioned a mandatory reporting requirement of the college. I'm unaware of that.
Oh, in the registration every year, as you get to the end of your registration, you will see a thing that says, is there any condition that I have medically or psychologically, I can't remember the exact wording of it, that could potentially interfere with my practice of medicine. And that happens on your every year renewal form with the college. And built into that is also the understanding that if you have a colleague that you think there's something going on with them, either physically or mentally, that's going to interfere with practice, you have an obligation to report to them. And that's appeared in their publications as well. We have a real concern about that, which we have voiced to them, that this is driving health underground. so that people are very frightened and reluctant to put anything on there on paper, particularly with the college, that would impugn their ability to practice later on. And the college remains largely a mysterious organization to my experience with physicians, and not recognizing how supportive they are of physicians who come forward with issues and questions and concerns they have about their practice. There is objective evidence that what I'm talking about is real, in that the numbers we've had have dropped off. As soon as that little line appeared in the registration of the college document, the calls that we got into to our organization for help dropped probably 20% and remained that way ever since. So now we're having an even bigger marketing campaign to try and make people aware of the fact that, in fact, the work we do is confidential, highly confidential, and in fact different from the college. And really the only time that we're involved with the college is if we have to do something where it will potentially impair patient care, and then we are an advocate. We go with people to the college, many times after treatment's completed, along with CMPA, to help set up guidelines, contracts, and everything about practice, so physicians feel fully protected. I hope that answers that question.
Yeah, no, it does. Thanks. Yeah.
I would have thought the college's primary responsibility is to protect the patients from us, the public from us, so that's their primary goal, isn't it? It's not necessarily to look after us.
That is exactly right. Their mandate is to protect the public. And so we as an organization, our mandate is to look after physicians. And that's why it's been a real nice complementary thing. Yeah. And we work not only with the college. In the university setting, we work well with the law office here now and the Office of Professionalism and the similar sister institutions at the University of Calgary. We're in contact with them virtually daily throughout the week.
Just one very broad question for myself. Bearing in mind the benefits of self-compassion to us as individuals and as a profession and to our patients, how do you see us changing? How do we make that change to becoming more self-compassionate?
Yeah, that's a very good question, and I think there are a number of ways that that happens. The first is something we didn't get a chance to talk about today, but could at another day, and that's more on the tribal nature of communication in exotic environments. So that much of the things that hold operating rooms and exotic or arcane environments together is the underground kind of social connections that the environment has. So it starts very simply. For instance, in our emergency room group, for the last 30 years, the 9 o'clock doctor brings the early doctor, morning doctor coffee. There was a period for about a decade where we used to get booster juices, but people can only drink so much booster juice. And now we know each other's coffees by heart. If somebody's pregnant, we change it up for when they're pregnant. And this has been going on forever. And the 11 o'clock doc brings coffees for the 9 and 6 o'clock doctors. Once a week on nights, the person on nights brings pizzas in for the night staff. And these are just daily simple rituals that increase the kind of social connectiveness. We have in our group for now, for many years, for many decades, instead of having regular departmental meetings in the hospital, we have business meetings at a dinner. We go out for dinner together. And we have rounds there and do morbidity, mortality, have business meetings, and then we have a social event at the same time. There's summer retreats, there's winter retreats. The business meeting becomes an annual Christmas event. So we build in a social network and fabric so that when we talk about work stuff, it's at the same time that we're talking about our families and our kids. And we know each other as people now. And then if something acute comes up, so for instance, my mother is suddenly critically ill in the nursing home, I can easily go to Marc if I'm working with him and say, Marc, I'm in trouble. I need someone to cover my shift tomorrow. And Marc, instead of thinking, oh God, I'm busy enough. No, my friend needs help. Absolutely. And we have done that in our particular group of emergency physicians. We've done that for many, many years and cover each other on acute short notice and not even questioned it. It's like part of the family. We consider each other family. I think that is how we become more self-compassionate, is by showing compassion to our workmates. We become more forgiving of ourselves then when we ask. We're less shamed when we ask for help. So I think by extending ourselves to others, I think the way is the way to do it socially. Does that answer that?
It does indeed, yes.